A few years ago, back in 2011, I learned about this technology from some physicians at the University of Minnesota and was so intrigued by the possibilities of restoring a microbiome that I found another partner and we formed the company and got it funded back in 2011. Subsequent to that, the goal was to create products to treat debilitating gastrointestinal diseases, starting out with Clostridium Difficile disease, which is an infectious gastroenterology disease that causes over 29,000 deaths each year in the United States. And today there's no real treatment for people who have had multiple occurrences of that disease, and our company is the first one to bring a product through the FDA to try to treat that disease. We are actually a pioneer in this area. We're the first group to bring a product through the FDA and to have a standardized quality controlled product that we can deliver directly to the patients. We've conducted multiple clinical studies and have demonstrated that it's effective for these patients who otherwise would have no other therapy. So we're very unique in the sense that our product is unique and we're moving forward independently of other competitors.
The PUNCH-CD trial is a phase 2 trial of the RBX2660, which is the product name for treatment of multiple recurrences of Clostridium difficile infection. It was a treatment-only trial. There was no placebo, and the primary goal was to reduce recurrences of C. difficile infection. The study that we'll be presenting actually, so we obtained funding from the CDC Prevention Epicenters, which Washington University is a center for, and so we got funding to get the specimens from Lee here and to analyze them to help better our understanding how microbiota restoration therapy helps to prevent recurrent C. diff. But not only that, we're also going to be examining the impact of this on other resistant bacteria that might be in the colon.
So the product that has been tested to date is an enema product. Okay. And we see that that's useful because it has fewer procedure-related complications than other delivery methods. We are currently developing an oral formulation, and the purpose behind that is because we see that there's more opportunity besides C. diff, and like Dr. DeBerke said, other diseases, other multi-drug resistant diseases, and sometimes those people need to be treated on a basis that's more often than just once, and so maybe they need to be treated once a day for a week. So, and why that's important is because we want this to be similar to other drug products where the patient can take it home and treat themselves and have a good outcome.
This is kind of the first step. This is, the first phase 2 trial like this in the United States. And it's not uncommon for there not to be a placebo. It's, the historical data do indicate it would be highly successful. And in this patient population's recurrences are very common by the patient population we had here, there's a 40 to 50, if not 60% chance they would go on to get additional recurrences if not for this therapy. And so kind of the bottom line for the phase 2 study, there was an 87% success rate. So a failure rate of only 13% versus, like I said, historically would be more in the 50-60% range.
Our patient group was an average age of 67, so they were quite elderly, and most of them were quite ill. So it was this group of patients is the reason we were so happy that it was so successful, because they're difficult to treat people, and they've had this disease for a long time.
Absolutely.
There were no serious adverse events related to either the product or the delivery of the product. There were actually, again, and this is one of the important things with doing clinical trials like this, collecting very good data to really know the risks and benefit. And so not described as well as was in this study, actually patients do have maybe some initial discomfort in the first day or so after the dose with some gas or abdominal cramping, but that went away quickly. But again, that was something that previously wasn't recognized to be as common as it actually is.
We were the first company to actually document every safety aspect of this product, and that information has been published along with what Dr. DeBerke is going to be presenting tomorrow.
of the concept for the route of delivery was enema by choice. At that point, only one person in the world had been doing pills, and what he was doing was pretty labor intensive. And it would be difficult to be able to replicate on a large scale beyond just a one person at a time basis. And so by doing it by enema, literally any physician can do it. You don't have to be a specialist. You don't have to be able to do colonoscopy. And the other benefit is then there's not the risk to the patient of undergoing one of those procedures. Though the risks are low, there are risks which aren't present with an enema. And then again, making it even easier will be the pill form. Again, with the goal being something that doesn't need to be frozen, can be maintained at room temperature that the patient can take.
The patients come into the office and they are treated within a few minutes and they go home. There's no preparation like you would have if you were having another colonoscopy procedure. So it really keeps it pretty simple for the patients as well. We've recently completed the enrollment in the first ever randomized placebo-controlled double-blind trial, which is like the gold standard clinical trial. And that the data for that should be available in a couple of months. Once that data is out, we'll be able to see at that time if there's another study that will be indicated. So we anticipate that will be, after that we'll apply for a biologic license. So we're pretty close to commercializing probably within the next few years.
And one thing I would say is the importance of getting patients into clinical trials like this to help advance the science, improve our knowledge, and then provide opportunities to do other studies to better define what makes for successful treatment versus a treatment failure, and to improve the product in the future. Right now a lot of people are doing this in the absence of any sort of clinical trial, and so there are many missed opportunities right now. So it's important if you're going to treat a patient with recurrent C-diff with some sort of microbiota preparation, do it in a clinical trial so we could advance the science and improve patient outcomes.
I just did a talk on the hype versus reality and pulled up headlines on different things I found over the last couple of months. And fecal transplant does this, it cures anxiety, it does autism, and finally there was a headline that says, fecal transplants cure the incurable. And I said, what more could you ask for? We got the miracle right here. But I think the point of that is patients' hopes get so high that they can be really disappointed if it doesn't work. So we think it's really important to conduct these trials. Our goal was to de-hype the process. And the only way that you can do that is really, I echo what Dr. DeBerke says, is to conduct clinical trials. There's a lot of therapies that have been done in the past where people get really excited about them and everybody wants one, but when the science really comes out, they're disappointed. And so we didn't want that to happen, which is why we embarked on the clinical pathway.